All right, thanks. Morning, everyone, for coming through this morning. Today we will presenting something very common and sure we treat every day, atrial fibrillation, some of the new developments in terms of how we should treat it and managing associated comorbidities. Dr. Mohammed is one of our cardiology fellows. He's going to be reviewing the latest European Society of Cardiology guidelines of how what we should be doing for in management. Published literally about 3 weeks ago, so it's really important. Welcome, Chris. Mohammed, thank you for preparing and looking forward to it.
I'd like to thank Prof. Tsabedze as well as the Department of Medicine for giving me this opportunity to present on a topic that not only plagues us cardiologists, but internal medicine and a range of specialists, as well as general practitioners. So to start, just to give a bit of a background, atrial fibrillation is a commonly encountered arrhythmia. The incidence and prevalence is increasing worldwide due to the increase in life expectancy, and with that comes an increase in comorbidities. It has a variable presentation. Patients often present with symptoms that are non-cardiac. We often just ask about palpitations, but a variety of symptoms present with atrial fibrillation. So a high index of suspicion is required. This arrhythmia has a marked impact on the quality of life, as well as stroke, heart failure, and systemic thromboembolism, and as a result is associated with high mortality. There's a change in paradigm to treat the drivers and comorbidities associated with atrial fibrillation and to prevent recurrence, treatment failure, as well as poor patient outcomes. Often in our settings, when we're seeing these patients in our outpatients department, we're trying to initiate strategies that often come far too late. And there's a shift now to try find what drives AF, how do we detect it early so that we can actually cure this arrhythmia. So what's new in the European Society of Cardiology 2024 guidelines? I'm going to try to save you 80 pages of reading that you can peruse at your own pleasure. But the focus is based on actually targeting, as mentioned, the risk factors associated with atrial fibrillation. A large amount of the guideline is devoted to this. And there are some minor upgrades with respect to certain sections. Currently, an electrocardiogram, it can be any form, whether it's a 12-lead, multiple lead, or single lead, is recommended to establish the diagnosis of clinical atrial fibrillation, and is also used to risk stratify and assist with management. Also, there is a greater emphasis on the symptoms that come with atrial fibrillation, not just at diagnosis, but before and after therapy and on every visit. Looking at key things like blood pressure control is recommended in patients with AF to prevent recurrent cardiovascular events, as well as targeting weight loss through comprehensive management in overweight and obese individuals to try and target the AF burden, and to try and target more than 10% reduction in body weight. Also looking at measures such as a tailored exercise program and to try reduce alcohol intake. There's also been an upgrade in surgical closure of the left atrial appendage, and it's seen as an adjunct to oral anticoagulation in patients going surgery for atrial fibrillation. And then on every visit, there's a great focus to manage and modify any risk factors that contribute to bleeding, and to try and make this as part of a multi-team approach to prevent consequences such as intracranial hemorrhage. Also, catheter ablation has now received a first-line option and is an effective way to to control rhythm, as well as prevent progression of atrial fibrillation. There are also different strategies such as endoscopic hybrid ablations. These are new on the forefront, and current trials are still undergoing to determine their effectiveness. So there are a variety of definitions associated with atrial fibrillation. There's a shift from using terms such as valvular, non-valvular atrial fibrillation, as well as lone atrial fibrillation. The way the definitions are based on a time-based approach. The four main ones are first diagnosed atrial fibrillation, atrial fibrillation that has never been encountered before, this is regardless of symptom status, pattern, or duration. And paroxysmal AF, this refers to atrial fibrillation which terminates spontaneously within 7 days or with the assistance of an intervention. Persistent AF, there's no strict time, but essentially it's atrial fibrillation that doesn't self-terminate. It lasts longer than 7 days, but there's no duration for, when does it become persistent versus permanent. And permanent just refers to a strategy where it's AF of long duration, where we accept that the atrial fibrillation is unlikely to terminate, and a sinus rhythm strategy is, or rate control strategy is pursued. Clinical atrial fibrillation refers to atrial fibrillation that's either symptomatic or asymptomatic, that's clearly documented either in ECG in the various forms, and the minimum duration is unclear. However, most of the studies mention atrial fibrillation that's more than 30 seconds. And then what's new on the horizon is everyone has these wearable technologies, this form of atrial fibrillation that's picked up is referred to as device-detected subclinical atrial fibrillation, which tries to pick up high atrial episodes, and confirmation is still required, ideally through an ECG. Plethysmography, which is often used in smartwatches, is an ideal way to detect atrial fibrillation. There's a whole lot of other terms, non-self-terminating, self-terminating, trigger-induced atrial fibrillation, but we won't be going through that. So just for the more junior staff, it's an ECG. It's ECG based with either a 12-lead or single-lead ECG. The duration is unclear. However, one could use 30 seconds as a cutoff. However, in single-lead ECGs, 12 seconds is acceptable. And it's more challenging in asymptomatic individuals to diagnose, especially devices that do not have an ECG function or mentioned earlier rely on plethysmography. So if we just look at this rhythm strip, we can see that there's varying RR intervals and absent P waves. In terms of the symptoms, as mentioned, it's highly variable. So commonly, the cardiac symptoms would be palpitations, but fatigue is often reported, as well as dizziness, chest pain, depression, disrupted sleep, and anxiety. That's more commonly in females. The presence or absence of symptoms is not related to stroke, thromboembolism, or mortality. Females are more symptomatic. They have a poorer quality of life with higher levels of anxiety and depression. And symptoms should be checked initially and before and after medication or any intervention. And we commonly use this tool. It's called the European Heart Rhythm Society Symptom Classification. It's similar to the New York Heart Association dyspnea score, and it's just a scoring system from 1 to 4 that reveals how symptomatic the patient is with atrial fibrillation. In terms of adverse events, heart failure is the most common, and it's a 5-fold increase in heart failure in patients with atrial fibrillation. This is followed by ischemic stroke, ischemic heart disease, and arterial thromboembolic events. There's also an increased risk of cognitive impairment and vascular dementia. Increased mortality most often is heart failure related, and the second most common is oral anticoagulation bleeding. Despite being on oral anticoagulation, there's a high residual death risk. So just in terms of a basic workup, as mentioned, a 12-lead ECG assessing symptoms, functional status, you're looking at bloods and FBC, HbA1c, a UNE and LFT and thyroid functions, and thereafter transthoracic echocardiography to look for any structural heart disease. So the care model is what's new in the ESC 2024 guideline. It's a patient-centered, integrated form of atrial fibrillation assessment that goes through comorbidities, risk factor management, avoidance of stroke and thromboembolism, reducing symptoms by rate and rhythm control, as well as a regular dynamic assessments, using a variety of healthcare professionals from primary care to specialists. But we will be going through that later. And so in terms of breaking down, the comorbidities, treating common ones like hypertension, heart failure, obesity, obstructive sleep apnea, alcohol, diabetes, and improving exercise tolerance, we can see most of these receive a first-line recommendation. Under avoidance of stroke and thromboembolism, it's starting oral anticoagulation, routinely using a Tsabedze score to assist in initiating oral anticoagulation with a score of 2 or more requiring anticoagulation, using the correct choice of anticoagulants, and regularly assessing bleeding risk and trying to see if there's any modifiable or reversible factors, and then also avoiding bleeding. So to avoid adding aspirin to oral anticoagulation to try and prevent stroke. The R is for reducing symptoms through rate and rhythm control, and the E is evaluation and dynamic assessment through managing risk factors, comorbidities, adequate stratification, and assessing the symptomatic burden of atrial fibrillation. So the treatment strategies for first diagnosed paroxysmal, persistent, and permanent AF, they do vary. This was just a nice diagram that was in the guideline. So for patients that present with first diagnosed atrial fibrillation, the key thing is to find out, are they hemodynamically stable? If they're not, they require electrical cardioversion. If they are stable, one addresses the AF care protocol and thereafter initiates a rate control. This is based on the ejection fraction. If the ejection fraction is less than 40%, beta blockers or digoxin is advised. If it's above 40%, beta blockers, digoxin, or calcium channel block in the form of diltiazem or verapamil is suggested. It has to be above 40% because these agents are negatively inotropic. Thereafter, cardioversion of symptomatic persistent AF may be considered, or one may pursue a wait and see. Some patients spontaneously revert, and that receives a class 2 recommendation. In terms of patients with paroxysmal AF, the aim is to look at the ejection fraction and, as mentioned, initiate therapy, either single therapy or combination therapy. And thereafter, it would be to assess rhythm control in the form of antiarrhythmic therapy or catheter ablation. And that's what's been upgraded, is that catheter ablation now receives a first-line recommendation as an upfront therapy for curing atrial fibrillation. In terms of the antiarrhythmic drug therapy prescribed, that's based on ejection fraction and whether there's underlying structural heart disease. If there is structural heart disease, then agents such as flecainide or dronedarone or profenone should be best avoided, and amiodarone is preferred. If there's still a recurrence, then one may pursue catheter ablation or may escalate medical antiarrhythmic therapy. And this is essentially similar for patients with persistent AF. However, we see that there's a downgrade in the recommendation for catheter ablation. And that just refers to the fact that catheter ablation is most successful in patients with paroxysmal AF. And the longer the time period a patient is in AF, the less likely one is able to ablate the arrhythmia. And in patients with permanent AF, it's similar based on ejection fraction. We initiate medical therapy. However, one may pursue an AV node ablation in CRT. Patients are severely symptomatic, and if they still have symptoms thereafter, can add on therapy to their antiarrhythmic prescription. So the management of the key comorbidities and targets, as mentioned, it's hypertension, targeting tight control, systolic blood pressure between 120 to 130, and a diastolic of 70 to 80. In terms of heart failure, it's optimizing diuretic therapy and anti-remodeling therapy and initiation of SGLT2 inhibitors. In terms of diabetes, it's trying to effectively reduce their glycemic control. Obesity, initiating a weight loss program and targeting a weight loss of more than 10%. Also managing sleep apnea, improving physical activity and effort tolerance, and trying to cut down on alcohol. In terms of initiating oral anticoagulation, so CHADS VAS score, as mentioned earlier, of 2 or more warrants initiation of oral anticoagulation. Oral anticoagulation is recommending all patients with AF, regardless of the CHADS VAS score, in patients with hypertrophic cardiomyopathy or cardiac amyloidosis. And it requires constant reassessment of thromboembolic risk to ensure that it's effectively prescribed. And the CHADS VAS score of one or more may be considered an indicator of elevated thromboembolic risk. And yeah. So the one difference is that the SC has been taken out of CHADS VAS. So female category is seen as a risk modifier, not as an absolute risk factor. So it's actually now a CHADS VAS score, not a CHADS VAS score, with the other parameters still saying the same, with age and previous stroke having the highest points awarded. In terms of the limitations to a CHADS VA score, certain risk factors are not taken into account, such as cancer, chronic kidney disease, ethnicity, biomarkers, obesity, smoking, hyperlipidemia, and left atrial enlargement. In terms of oral anticoagulation, dual oral anticoagulation therapy has been found to be non-inferior to warfarin for the prevention of thromboembolism, and it's associated with the 50% reduction in intracranial hemorrhage, stroke, systemic embolism, as well as mortality. DOACs are also safe in mild to moderate CKD as long as the GFR is above 30. Once it starts dropping below that, specific dosing applies, with rivaroxaban, apixaban, and indoxaban requiring dose reduction with the GFR between 15 to 29. Dabigatran is the most renally eliminated, so it's contraindicated at a GFR below 30. And in hemodialysis patients, in small trials done, apixaban 2.5 BD or warfarin is an alternative. DOAC therapy is most importantly, it should be avoided in moderate to severe mitral stenosis, as well as patients with prosthetic valves. And one could consider swapping from warfarin to DOAC if the time in therapeutic range is suboptimal, less than 70%, or if a patient is at a high risk of intracranial hemorrhage. So there's just certain criteria that determine DOAC dosages. I won't be going through all, but commonly it's age, body weight, and serum creatinine. So what about oral anticoagulation in subclinical device-detected atrial fibrillation? The data is unclear. The Artesia trial showed that the primary efficacy outcome of stroke, systemic embolism, was lower in the apixaban versus aspirin group. However, in the Nqoba trial, it was stopped prematurely due to futility in the apixaban arm, and it was no different in the composite of cardiovascular death, stroke, or systemic embolism, and there was a higher associated risk of bleeding with apixaban. So the current recommendation is that DOAC therapy is recommended for asymptomatic device-detected atrial fibrillation in patients with a high stroke risk. So it should be based also on doing a CHADS VAS score and obviously a low bleeding risk. In terms of assessing the bleeding risk, it requires a comprehensive medical history, and most importantly, bleeding scores do not determine whether a patient should be initiated on oral anticoagulation or not. It shouldn't guide initiation. It should be used as a method to address the risk factors. And once again, targeting blood pressure, avoiding unnecessary antiplatelet drugs, reducing alcohol, trying to optimize the INR between a level of 2 to 3 with a time and therapeutic range of more than 70%, avoiding NSAIDs, are ways of minimizing bleeding. And most importantly, it's to try and identify whether there's any modifiable risk factors such as anemia, low platelets, renal function, is a patient diabetic, is a patient at risk of falling or in congestive heart failure. And the more non-modifiable ones would be age, a history of previous bleeding, malignancy, any organ dysfunction, or cognitive impairment. So atrial fibrillation in terms of rhythm control, cardioversion should generally be considered. If sinus rhythm is not restored, a trial of amiodarone may be done, and then a patient can be retried. Failure of cardioversion portends a poor prognosis for atrial fibrillation. And in the absence of symptoms, restoration of sinus rhythm may actually reveal that symptoms were present. So what are the indications for atrial fibrillation ablation? So if a patient has symptomatic paroxysmal atrial fibrillation or persistent atrial fibrillation, to try and maintain sinus rhythm and minimize the atrial fibrillation burden. Early rhythm ablation actually improves AF ablation success, and antiarrhythmic drugs, if not tolerated or contraindicated or ineffective, are further indication for atrial fibrillation ablation. It's a first-line option for patients with paroxysmal AF less than 60 years old and fewer comorbidities in the studies that were done. And in terms of one has to weigh up the risk and benefits and actually counsel the patient, as it's not an innocent procedure. Complications include peri-procedural death, stroke, transient ischemic attack, pericardial effusions, pulmonary vein stenosis, vascular injury, as well as phrenic nerve palsies, and atrial esophageal fistula. So who is likely to benefit from rhythm control? So large registries of asymptomatic patients where rhythm control was attempted, there was improvement in stroke, death, and heart failure. The largest impact was in patients with paroxysmal AF and left atrial size less than 5 centimeters and a high CHA2DS2-VASc score. Poorer outcomes were associated in patients with obesity, a large LA volume index, ischemic heart disease, infiltrative cardiomyopathy such as amyloid, as well as cor pulmonale and severe mitral valve disease. Atrial fibrillation in the context of heart failure with preserved ejection fraction, it's unclear. The trials have been inadequate. And in terms of atrial fibrillation recurrence, contemporary trials reveal that 30 to 40% of the AF recurs post-ablation. Repeated ablation also is associated with complications such as pulmonary vein stenosis and an entity called stiff left atrial syndrome. In long-standing and persistent atrial fibrillation, a combination of ablation and medical therapy has been found to be successful. And antiarrhythmic therapy for the first 3 to 6 months post-ablation often reduces occurrences at a year. So in terms of catheter ablation, just a brief summary, it's the most established evidence-based technique revolves around pulmonary vein isolation using either radiofrequency or cryoablation. There is an alternative method, which is hybrid AF ablation, which combines catheter ablation with minimally invasive surgical ablation. And this is achieved through thoracoscopic access to the epicardial surface. There is a new technology called pulse field ablation, which is where non-thermal catheter ablation technique is used to target electrical fields and to target the associated tissue. And studies suggest that there's greater safety with reduced damage to neighboring structures using pulse field ablation. However, randomized control trials are still to reveal how this technology compares with older technologies such as radiofrequency and cryoablation. So this was just a diagram that shows what mapping looks like in the EP lab. On my right it illustrates asynchronous activation of the atria, where on the left we can see that this synchronicity, and ultimately it measures the conduction of tissues. So in atria, and it maps the foci. We can see that down below. In acute AF, we just have a few foci, but as a patient progresses from paroxysmal to permanent atrial fibrillation, these foci become larger and more frequent. So the take-home message is that atrial fibrillation is a patient-centered integrated approach to management using a holistic approach to address comorbidities, risk factors, avoid stroke and thromboembolism, and ultimately to reduce symptoms through rate or rhythm control. It requires a continuous evaluation of symptoms and ischemic and embolic risk, as well as assessing bleeding to optimize anticoagulation. Early rhythm control is essential, and the importance of catheter ablation as a first-line therapy and its superiority over drug therapy in selected